Well, that's a wake-up call if I've ever heard one. Pulmonary function. There's so many, right? Nobody else is out there? We'll just go ahead and get started and they can listen to the recording. Okay. So we mentioned flow volume loops last week. And when the patient's doing a forced spirometry, they take a deep breath in, they blow really hard. The computer keeps track of the flow as they're blowing and also keeps track of the volume and then puts it together on one loop. So we're going to look at different loops. It says the FVC and the FIVC are recorded in succession. So what does that stand for? Forced vital capacity. And then what's FIVC? Vital capacity. Yeah, that's taking a deep breath in. So you have the patient take a deep breath in. You hit the space bar or whatever it is you do on the computer, and then they blow. Blow, 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 blow. You try to get 6 seconds and then take a deep breath in. And it's after they take the deep breath in, you end the test. So they're blowing out, breathing in, and then you end the test. It says the flow is in liters per second, plotted on the vertical axis, and the volume in liters is plotted on the horizontal axis. Expiratory flow is plotted upward. Inspiratory flow is plotted downward. So that the horizontal axis or the x-axis, that shows volume. So if you look at where it starts to where it ends, that gives you the volume of the forced vital capacity. And then the y-axis, the tallest point, tells you the fastest peak flow. So some of the values that you get, the peak expiratory flow rate, the peak inspiratory flow rate, FEF 25, 50, and 75. Flow rates are a reflection of airway caliber, elastic recoil of the lung, and patient effort. So if the patient's not understanding the language or doesn't understand instructions, you might see slow flow rates, but they're just not giving you their best effort. And it'll show up in the flows. So the peak expiratory flow rate is the maximum flow generated during exhalation. It is the highest peak on the flow volume loop. So when you look at the very top and then look to see how fast that flow rate was, it's typically 5 to 8 liters per second for adults. Then if you look on the very bottom, the lowest point that it goes, that tells you the maximum flow during inspiration. So at the very bottom is the peak inspiratory flow. Okay, and then you can look at the flows at different points of the patient blowing out. So if you see FEF 25%, what does that mean? So it tells you this is the flow rate that's being generated at the time 25% of the vital capacity has been exhaled. So the computer divides it up and says, oh, okay, 25% of the vital capacity was exhaled. What is the flow rate at that point in time? And then it sticks it on the graph. So after 25% of the volume has been exhaled, it'll be a good number if the airways, the large airways, are wide open. So FEF 25, it's a reflection of the large airways. So your trachea, your bronchi. FEF 50% is the flow after half of the vital capacity has been exhaled. It's effort dependent. It's a reflection of the medium to small airways emptying. So this is the bronchioles, would be considered medium to small airways, the small bronchi and bronchioles. And when we look at the flow rate after 75% of the volume has been exhaled, it tells us how well the small airways are emptying. When we're looking at FEF 75, it's not effort dependent. And it just reflects it says elastic recoil and flow resistance of the small airways. Okay, here's a math problem. Do you have your phones to use your calculator? Find the flow rate at FEF 25%. So it wants us to find when 25% of the volume has been exhaled, what is the expiratory flow? So it tells you, first you have to know the vital capacity. And can you see what the vital capacity is on this loop? 3 liters. So that's our vital capacity. And we want to know 25% of 3 liters. So on your calculator, you can do 25% and then times 3, or you can do 0.25 times 3. You got 0.75? All right, so everybody knows how to do that? So it says, look on the flow volume loop, find when 0.75 liters have been exhaled, which would be right about here before the 1 liter. And then straight up, yeah, right, like I can do straight up. And what is the flow at this point in time? Maybe around 6 liters per second. Yeah, so we'll go with 6 liters per second. All right, let's do it 2 more times so that when you get your next test, you're going to be pros at doing this. So it says FEF 50%. What is the flow rate? So FEF 50% of what? 3 liters would be how much volume? 1.5 liters. And then go straight up. What is the flow at that point in time? 4 liters per second. Very good. Okay, do it 1 more time to make sure you understand. Now I want us to know what the flow rate is when 75% of the volume has been exhaled. All right, so 2.25 liters, 0.75 times 3. Okay. So 2.25 liters go up, or was it 2.75? 2.25. Okay, so right about here, you go up, and then you come across, and what is the flow at that point in time? 1.5 liters, somewhere around 1.5 liters. So that would be your answer, 1.5 liters per second. Tiffany, do you need to say something? Thank you. All right, so that was it for full volume loops. look at all these different shapes for flow volume loops. When you look at the shape, you can kind of tell what's going on with the patient. So first it shows you a normal flow volume loop. So initially there's a lot of flow, so you see it's tall. There's good volume, so it's kind of fat. So tall and fat is good. The next one, it's tall and skinny. So that tells us there's good flow rate, but the volume is really small. And that's very typical of somebody who has a restrictive lung disease. So their volumes will be reduced, but their flows are good. I thought I had some other notes on it, but I don't. All right, next one, it says small airway obstruction. So as the patient is blowing out, they're not able to get much air out per second, and that's why it has, the flow is less, and it's also kind of scooped out. Does that look scooped out to you? Compared to the straight line for normal? So when you see that scooped out appearance, that tells you that there's airway obstruction occurring. Say it loud. The flat bottom? Oh, I see. The flows when they breathe in are pretty good. I mean, here's normal. They are reduced a little bit, but the flows coming back in are fine. So typically what happens is when we breathe in, the negative pressure pulls on the lungs and it pulls the airways open a little bit. During exhalation, everything closes down a little bit. So when the diaphragm comes back up, the rib cage goes down, the airways get a little bit smaller. So they open up bigger during inspiration and they get a little bit smaller during exhalation. And that closes off the expiratory flow. But typically patients with an obstructed airway, they can do fine breathing in. So usually their inspiratory flows are pretty good. All right, the next one is called fixed large airway obstruction. So the word fixed just means that it's the same during inspiration as it is during exhalation. And this is typical if there's a large airway obstruction. So like a tumor in the trachea. Anytime you see the word fixed, it means that the flows are the same during inspiration as they are during exhalation. Am I going too fast? Oh, okay. I just want to get it out before you guys fall asleep again. So the large airway obstruction, it's hard to blow out and it's hard to breathe in. A tooth into their trachea. Yeah, it might travel all the way down until it obstructs a bronchus. But if it's not obstructing a bronchus, then yes, you would see reduced flows. Good point. Or what if they had an endotracheal tube in for a long period of time and they developed some granulomas in the trachea? So that would reduce the flows. All right, the next one is intrathoracic, variable, large airway obstruction. So intrathoracic means inside the thorax. So everything in the rib cage is intrathoracic. So as soon as you're outside the rib cage, and that would be your larynx, not your trachea, I guess all of your trachea is inside. So your larynx is outside. That would be extrathoracic. but everything in the rib cage is intrathoracic. And then the word variable. So it's different during exhalation as it is during inspiration. So somebody who has a large airway obstruction, they can breathe in fine, but then they can't blow back out. And I'm going to give you examples of all of this in a second.
Isn't that one just kind of like the obstruction or a small? Oh, wait.
I've got examples coming up. The last one is extrathoracic variable large airway obstruction. So extrathoracic will be outside the thorax, which could be a tumor on the vocal cords or a paralyzed vocal cord, or what are some of the tumors? Didn't you guys have one at Cleveland Clinic? A tumor grew into their trachea. So I don't know if they had a pulmonary function done. But that's trachea, that's not vocal cords. All right, so what happens with outside the thorax? When you breathe in, everything kind of gets pulled together. But when you blow out, everything opens back up. So outside the thorax is opposite than inside the thorax. I think I'm getting ahead of myself. Let me just go to the next slide. The shape of the flow volume loop is helpful in assessing the type and location of upper airway obstruction and whether the obstruction is within or outside of the thoracic cavity. So it starts off with a fixed large airway obstruction, and it shows something going on in the trachea, maybe like a tumor. It says the obstruction is fixed. It does not change shape with changes in pulmonary pressures. The flows are limited during exhalation and inhalation. And the examples are thyroid goiters. So when the thyroid gland becomes really enlarged, it impinges on the trachea. So that could cause a fixed large airway obstruction. And the other example is tracheal stenosis. So something that narrows the trachea is going to cause a fixed large airway obstruction or poor patient effort. Now we have variable. That means it's going to be different between inspiration and exhalation. Negative pressure during inhalation opens the narrowed lumen. Negative pressure pulls it open. So they can breathe in fine. You see how the inspiratory part of this loop is perfect because the airways are large enough, or they open up and air can go in. But on exhalation, the positive pressure closes the airways a little bit and you don't get good flow. It says tumor in the mainstem bronchi can cause this. And there's an exception. Tracheomalacia. The cartilage has been damaged and it collapses during inhalation. Yeah. Yeah, kind of like a flap, because if you don't have the structure of the trachea, if you're missing a cartilage, it'll collapse when you're breathing, when you're blowing out. Yeah, there's it looks like a screen or a netting that they put in. They do that with, like, when infants are on the ventilator, and by the time they're, you know, they've been on a ventilator for like 6 months, the cartilage in their trachea is so soft They end up putting a stent in, a tracheal stent. Yeah. And then as they grow, they've got to take it out and put in a little bigger one until they grow out of it. All right, now check out this flow volume loop. There's good flows on exhalation, but terrible flows during inspiration. So that tells us that it's occurring outside of the thorax. It says negative pressure during inhalation pulls the upper airway inward. Positive pressure during exhalation opens the obstruction, like vocal cord prolapse, laryngeal tumor. It's like, can't breathe in, but I can breathe out just fine. To keep the airway open? Yeah. Yeah, some CPAP makes a big difference. So this was a case study that was posted online. A 47-year-old man is referred for evaluation of exertional dyspnea. His past medical history is notable for ARDS due to H1N1 influenza a year and a half ago that required prolonged mechanical ventilation and a tracheotomy. Already you're thinking problems with the trach, right? He was decannulated 6 months ago and has not required supplemental oxygen. He did well until several weeks ago when he noticed increasing dyspnea with physical activity. So office spirometry. So doctors' offices will perform pulmonary function tests. Typically they have like respiratory therapists working for them part-time. With the shortage of respiratory therapists, I have no idea what they're doing in doctors' offices. I wonder if they just train some of the technicians in the office to do it. But anyway, they got the spirometry done, and this is the flow volume loop. What do you think? Expiratory flows, are those good? Right, they can't blow out very well. They can't breathe in very well. So tracheomalacia or tracheal stenosis. Okay. Okay, tracheal stenosis. CRD, C or D. It's tracheal stenosis due to granulation tissue formation. The flow volume loop can reveal evidence of a fixed airway obstruction with flattening of both the inspiratory and the expiratory limbs of the flow volume loop. So choice D. And then if tracheomalacia, if it was tracheomalacia, we would see variable intrathoracic airflow obstruction. Yeah, I wonder if they go in and get rid of some of that scar tissue and extra tissue. Tidgen? Right, yes. So let's do that. Let me go back to the original one. Yes. Very good, yes. All right, so we'll start off with that one first. I have 8 different examples, and we have to pick the right flow volume loop. So the first one for tracheal stenosis, and you've got all that granuloma tissue kind of narrowing the trachea. Which one is it? Let's put numbers on this. Where's my little? Where's my little pencil and pen? That's crazy. It's always at the top. One more try. Nothing. And nothing to write on. Something smells good. All right, I give up. So I can't write it. So on your, oh, you don't have paper. Well, let's just give it a number or call out the name as I say something. So the tracheal stenosis was fixed large airway obstruction. Next one is small airway obstruction. Oh, that's too obvious. All right. All right, what about this one? Prolapsed vocal cord. And so if you're extrathoracic, when you breathe in, that's going to close off the flow. So that's why we have 1, 2, 3, the 6th one, where you don't have much flow during inspiration. And that's because anything extrathoracic collapses when breathing in. Next is restrictive disease. Too easy? Okay. How about this one? Tracheomalacia. Yes, very good. Intrathoracic large airway obstruction. Tumor in the right mainstem bronchus. In the right mainstem bronchus, do you have a tumor? So you can breathe in past the tumor, but you can't exhale. You say fixed? What have I got on my notes? Number 5. Intrathoracic variable. So you can breathe in during inspiration when the airways open up, but when you try to blow your air out, the airways are narrower and the air gets stuck. So you can get it in, you just can't get it back out. Poor effort. Restrictive, no. Yes, it would look like this one. They're not trying during exhalation and they're not trying during inspiration. So it looks like this. That's your scam artist. Or somebody who doesn't understand instruction, or somebody who's really weak. So if somebody's blowing really hard, but they have airway obstruction, you'll get that scooped out appearance. But if somebody's trying to not do their best, you're not going to get much flow when they're blowing out or when they're breathing in. Yeah. Yes. No effort during inspiration, no effort during exhalation. Yeah. Mary? The condition? Poor effort. And what about normal flow rates? And that's all I have. So does it sound confusing or does it sound pretty straightforward?
Yeah.
Oh, okay.
Ourselves, so like, so we feel like, all right.
Okay.
Just looking at the shapes, looking at the shape of the full body is part of the knowing.
Yes. Yeah, so can you tell which one they have an easy time breathing in, but a hard time breathing out? Yeah. So you see how this line comes down pretty far? That tells you that that's normal. So they can breathe in okay, but they can't exhale okay.
Explain the difference between the small area obstruction and the large area. I'm sorry, the intra variable large airway. Small. Because I thought they both had trouble taking it out.
Oh. Patient with COPD or asthma, their flow volume loop will look like this. So they have pretty decent flow rate for the trachea and bronchi to empty. But then as their medium and small airways empty, not so much. So it's a little tall at first, and then it has that scooped out look because the flow from the smaller airways is so diminished. Compare that to this one. You don't get any peak flow initially. So I guess that would be the difference between the two. And then when you're looking at this last flow volume loop, when the patient's blowing out, are they able to do so? No, out here at the top is blowing out. Yeah, they can blow it out just fine, but when they try to breathe in, they can't. You do? You're welcome. So the first page was to give you practice drawing a flow volume loop, because at the top it tells you the vital capacity is 3.5 liters. So then you go over to the x-axis and you put a dot where it's 3.5 liters. Then at the different flow rates, it tells you the volume and the flow, and then you put dots, and then you connect all your dots together and you come up with a flow volume loop. But to save time, I kind of didn't hand that out. So on page 2, you want to be familiar with page 2. because you will be seeing this page again soon. All right, so the one at the top left, it's supposed to be normal, but apparently the patient didn't have their nose clips on. So there's little divots in that normal flow volume loop. But that's normal. The one next to it, do you see how scooped out that is? So you get an initial good flow rate, and that's it. After that, the small airways emptying, the flows are really reduced. And it says underneath it, COPD, like emphysema, chronic bronchitis. On the bottom left, it's another airway obstruction, but not as severe. So you see how it's scooped out, but not as severe as the one on the top right. And it says early small airways disease. So maybe COPD or when they're younger or whatever. And the one on the bottom right, very good. And you can tell because it's tall and skinny. Good flows, but not much volume. And then to talk about, if you have an asthmatic and you give them a peak flow meter, oh, I gotta go to that. So for asthmatics, for them to keep track of how well they're doing, you can give them a peak flow meter and show them how to use it. I don't know if you did that. Typically in the ER, when they come into the ER, you can get a peak flow meter, measure their peak flows, and then give them a treatment and see if their peak flows improve after the treatment. So you have to know what their normals are. And there's a piece of paper that comes with a peak flow meter, and you look up the age. What else does it go to? And height. And you can look to see what's normal for them. Okay, that's all right. It's recording. So it gives the flow rates in liters per minute or in liters per second. And how can you remember like just one set of numbers? And then how about if you look at adult males? 450 to 750 liters per minute is considered normal for healthy lungs. A little less for adult females and less for pediatrics. So maybe in your mind, just keep 450 liters per minute as like a normal flow rate instead of trying to memorize all these numbers. And same thing with peak flows. 8 liters a minute to 12 liters. I said it wrong. 8 liters per second to 12 liters per second. And for pediatrics, a little less. And adult females, a little less. All right, set up a zone system for an asthmatic. Zoe is 16 years old. She has asthma. She's being controlled with long-acting beta-2 agonist and inhaled corticosteroid. Pardon me. What medication do you think she's getting? A LABA and a steroid. And when they're together, what MDI is that typically? Symbicort is just the steroid part, right? Symbicort has 2, bronchodilator and the steroid? Yes. Very good. The physician wants you to teach Zoe how to keep track of her peak flow rates by use of a peak flow meter. You have instructed her on proper use of the peak flow meter. What is properly using a peak flow meter? Is it taking a deep breath and blowing all your air out? Yeah, so a forced exhalation or blow hard? Okay. Yeah, so it's not a forced vital capacity. So you're not trying to get a lot of volume out of them. You just want to see how fast their flow rate is. So it's like a fast puff of air. Okay, so Zoe recorded her peak flows morning and evening for 2 weeks. You noted that her personal best is 6 liters per second. Set up a green, yellow, and red zone for Zoe. So green is 80 to 100% of her personal best. So 80% of 6 liters. 4.8. Yellow is 50% up to 80%. So 50% of 6 liters. Right, 3 liters per second. So when it gets down to 50%, an acute episode may be starting. And typically she needs to call her doctor and they'll increase her meds, give her more steroids, and a short-acting beta agonist is necessary. But what if it's less than 50%? What would you instruct her to do? Go to the ER. So less than 50%, she probably needs an IV with steroids in it at that point. So you would instruct her to go to the ER. Yeah. Our pharmacist here. And then I have to tell you about exhaled nitric oxide. If you have inflamed airways, when you exhale, there's all of this nitric oxide that comes out of your lungs. It can be measured with a device. And if it's more than 30 parts per billion, you have an acute asthma episode. So if you blow out extra nitric oxide, more than 30 parts per billion, you have an acute asthma episode. I don't know anybody who uses this, but it is on your national exam, so I want to go through it. Oh, that was it? Okay, I know you guys are saturated. Thank you for listening through. I will end the show.